Hello, good morning. My name is Otema BT, and this is the first part of a series of presentations I'm going to give you with regards to abdominal sonography. We're going to start with a general introduction. We're going to go over a number of aspects to abdominal sonography. So the information contained within this presentation is important for you. It's important for you so that you can obtain and recognize vital clinical information from patients. As radiologic technologists, you will need to be able to interpret certain laboratory results, as well as obtain information through patient inquiry. And so we'll talk about some of these relevant laboratory findings. We will go over some image artifacts, as well as a brief overview of the physics, instrumentation, infection control, and so on and so forth that are used in sonography. So we begin with a synopsis of key terms. These are terms that you're going to find as you go through your profession. I will briefly describe each and every one of them, but I have 2 slides of them. We'll begin with anemia. Anemia is a condition in which the red blood cell count is decreased. Anticoagulation therapy is a drug therapy in which anticoagulant medications are given to patients to slow the rate at which blood clots. Ascites is a collection of abdominal fluid within the peritoneal cavity. Chromaffin cells are cells in the adrenal medulla that secrete epinephrine. Clinical findings. This is information gathered by obtaining a clinical history. And then clinical history, these are the patient's signs and symptoms, pertinent illnesses, past surgeries, laboratory findings, as well as results of other diagnostic testing. Coagulopathies, these are disorders that result from the body's inability to form blood clots. Computed tomography is an imaging modality, uses cross-sectional images of the body. Elastography, this is a sonographic technique employed to evaluate a mass based on its stiffness. And we use it to provide a prediction as to whether a mass is most likely malignant or benign. Endoscopy. Endoscopy is a means of looking inside the human body using an endoscope. Exudate-ascites, it's a collection of abdominal fluid that is associated with cancer. Ephloid fluid level is a distinctive line seen within certain complex cysts, and it represents the layering of 2 different fluid densities. Gastrin is a hormone produced by the stomach lining that is used to regulate the release of digestive acid. Hematocrit, this is a laboratory value that indicates the amount of red blood cells in the blood. Homeostasis, the body's ability to maintain internal equilibrium. Hyperthyroidism, a condition that results from overproduction of thyroid hormones. It's an opposite to hypothyroidism, which is the underproduction. Intraluminal, something located within the lumen, and lumen is an opening of an organ. Intraperitoneal, this relates to located within the parietal peritoneum. Kaposi sarcoma, this is a cancer that causes lesions to develop on the skin, and it's often associated with AIDS. Leukocytosis, this is an elevated white blood cell count. Lymphadenopathy, this is a disease or enlargement of the lymph nodes. Lymphedema is a buildup of lymph that is most likely caused by the obstruction of lymph drainage. We go on to the next slide. So mass effect. Mass effect is a displacement or an alteration of normal anatomy, and it's usually adjacent to a mass or a tumor. Or Morrison's pouch. This is a space between the liver and the right kidney. We also refer to this as the posterior right subhepatic space. Multiloculated, meaning it has many cavities. Mural nodules, these are small solid internal projections of tissue that originate from the wall of a cyst. Nosocomial infections, these are hospital-acquired infections. Nuclear medicine as a diagnostic imaging modality. Oncocytes, these are large cells of glandular origin. Paracentesis, in this procedure we use a needle to drain fluid from the abdominal cavity. The parietal peritoneum, this is a portion of the peritoneum that lines the abdominal and pelvic cavities. The pineal gland is an endocrine gland located in the brain that secretes melatonin. Radiography is a diagnostic imaging modality that uses ionizing radiation. Retroperitoneal, posterior to the peritoneum. Serosal fluid, the fluid that is secreted by the serous membranes to reduce friction. Signs is objective evidence of disease. Sonographic findings, this is information gathered by performing a sonographic examination. The space of Retzius, this is a space between the urinary bladder and the pubic bone, and we refer to this as the retropubic space. A standoff pad, this is a gel used to provide some distance between the transducer face and the skin surface. Symptoms is any subjective pieces of evidence of disease. Thoracentesis, this is a procedure to use a needle to drain fluid from the pleural cavity. The thymus gland is a gland of the immune and lymphatic system located in the chest. Transudate ascites, this is a collection of abdominal fluid within the peritoneal cavity, often associated with liver cirrhosis. Tumor markers, these are substances produced by cancer cells. Unilocular, having a single cavity. Visceral peritoneum, the portion of the peritoneum that is closely applied to each organ. Voiding cystourethrogram, this is an examination used to evaluate the lower urinary tract. Wilson's disease, this is a congenital disorder that causes a person to retain excessive copper. So the normal echogenicity of abdominal organs is as follows. That is to say, from brightest to darkest, we have the renal sinuses as being the lightest objects that we can see in the abdomen, followed by the pancreas becoming more hypoechoic, the spleen, the liver, the renal cortex, the renal pyramid, and the gallbladder. So if we would see someone or a patient who would have, let's say, a right kidney appearing more echogenic than the liver, then we should examine for any deviant sonographic findings. So there's some sonographic descriptive terms that are quite general. We have anechoic, it means without echoes. For example, the gallbladder lumen, and you can have a simple renal cyst. You can have complex in terms of echogenicity. This how maybe an ecotexture, like in this case we're talking about cystic and solid components. For example, hemorrhagic cysts made with blood, some steroid starts to degrade. You get that sort of mixed, complex presentation. Hepatic abscesses as well. Something can be described as echogenic. That is to say, on sonogram it produces echoes, and the fatty liver is echogenic, as well as chronic renal disease. We can have a heterogeneous or homogeneous composition, right? And heterogeneous, different composition, homogeneous of uniform composition. And diffuse liver metastases make the liver appear as heterogeneous, as well as Graves' disease makes structures appear heterogeneous. The normal liver is usually homogeneous in terms of ecotexture and echogenicity, as well as a normal testicle. And in this case, it is a testicle outlined by the tunicular beginia. Hyperechoic, having many echoes, like a cavernous hemangioma and an angiomyolipoma. Hypoechoic, having few echoes, hepatic adenoma or a thyroid adenoma. Isoechoic, having the same echogenicity, like focal nodular hyperplasia. So, what are some of the indications for an abdominal sonography, an abdomen sonogram? We can have any kind of abdominal pain, signs or symptoms of jaundice, in this case the yellowing of the skin, yellowing of the eyes, palpable abnormalities, such as an abdominal mass, or if there's organomegaly, abnormal laboratory values. We'll talk about those as we continue. You can have anything that is suggestive of any abdominal or retroperitoneal pathology, or follow-up of suspected abnormalities. You can have a search for metastatic disease or a hidden primary neoplasm. There can be cases of trauma, and so on and so forth. So we want to prepare a patient, and patient preparation would involve a fast, and the fasting time depends. Some practitioners suggest that patients fast for 8 hours. Some suggest that a 6-hour fast is sufficient. For renal sonograms, the patient is typically required to fast, although some facilities might perform the examination when the patient is well hydrated. And this is especially true if the urinary bladder needs to be assessed. For any intraluminal masses, irregularities, or stones, diabetic patients need to be scheduled early in the morning to prevent hypoglycemic episodes. Abdominal sonography should be performed prior to radiologic examinations that utilize barium contrast. If we have any pediatric patients, we must perform our sonography on pediatric patients after radiographic examinations. For pediatric patients, we typically perform the sonogram first and then the radiographic examinations later. Small part sonography, scrotal thyroid does not necessarily require patient preparation. and the sonographic imaging process should be clearly explained to the patient. And it is imperative that you obtain thorough clinical history. You should perform these examinations when there's a valid medical reasoning, and there are no absolute contraindications to abdominal sonography. When we're describing pathology, we describe it sonographically with relation to the surrounding or adjacent tissue. For example, a hepatic mass may be described as hyperechoic compared to its surrounding echotexture. A renal mass may be described as hypoechoic with a central area of increased echogenicity. And then a cyst might fit certain criteria. We might call it simple, we might call it complex. But a simple classification for simple cysts would include smooth walls or borders. A cyst would demonstrate through transmission or posterior enhancement. Cysts are round in shape and are anechoic, and we call this the STAR criteria. STAR stands for smooth walls, through transmission, anechoic, and round in shape. When we look at complex cysts would be adding some internal debris or some internal septations or mural nodules, and they would demonstrate a fluid level. And they may not necessarily be round and would be described as multiloculated. And occasionally, with contrast-enhanced ultrasound with superior resolution, a diminutive amount of internal debris may be noted within a simple cyst. But if your simple cyst corresponds to the STAR criteria, it would be advisable that you classify it as a simple cyst. So then we come to clinical history. So a review of prior examinations and relevant documentation should be performed by the sonographer before any contact with the patient. That is quite important. You should gather thorough clinical history. That is, if there are any previous sonograms, you should review them. Any previous radiographic scans such as CT, MRI, nuclear medicine, or any other procedures or anything to do with endoscopy, you should review those. And any additional related laboratory and diagnostic reports. There are certain labs that sonographers must be capable of analyzing. And, for example, if a patient has leukocytosis, we would be looking for an elevation in white blood cell count. And this would indicate the presence of an inflammatory response to an infection. Patients who would have some form of itis, like cholecystitis, pancreatitis, or possibly even an abscess, will most likely have an abnormal white blood cell count and an existing infection. Although conversely, a decrease in hematocrit might indicate bleeding. And in patients who have suffered recent trauma or have an active hemorrhage, they will most likely have a decreased hematocrit level. So basic patient care. This includes assessment of body temperature, pulse, respiration, and blood pressure if needed. Sonographers should be competent at transferring patients safely from wheelchairs and stretchers to the examination table. And we should be mindful of IV therapy or any urinary catheter needs. For patients with IV, the IV fluid bag should be continually elevated in order to prevent retrograde flow. For urinary catheter care, the urinary bag should be placed below the level of the urinary bladder. and a means to prevent retrograde urine flow that could result in a UTI. I think that is quite straightforward. Stasis of urine can aid in bacterial growth. So previously we had talked about certain laboratory metrics or findings that sonographers should be aware of. And these are but a few of the sheer number of laboratory findings that are available. But these are of importance to sonography, and I will detail each of them, but perhaps I'll go through a small generalization first. So alanine aminotransferase. So with alanine aminotransferase, this is aggregated in the cytosol of hepatocytes, and these are enzymes that are normally detectable at low concentrations. However, there are certain processes that lead to the loss of hepatocyte membrane integrity or necrosis, and these enzymes are released into the blood. And these would indicate some hepatic disease or pancreatic disease or biliary tree disease. So whenever we test for alanine aminotransferase, in this case aspartate aminotransferase or alanine aminotransferase, we are investigating hepatic disease, pancreatic disease, and biliary tree disease. And then we come to albumin. Albumin is an indicator of liver function, and in cases of hyperalbuminemia, it can reflect a decrease in albumin synthesis. And if we have a decrease, it could indicate that the liver's biosynthetic capacity has been reduced, and as such we can conclude that the liver is damaged somehow. Alkaline phosphatase, its increases are related to biliary obstruction, liver cancer, pancreatic disease, and gallstones. And if we have an increase in hepatic enzyme activity, it corresponds to the elevation in serum alkaline phosphatase levels. And so that is what it indicates. If it is decreased, it indicates Wilson's disease. And ALP is newly synthesized as a response to biliary obstruction. Aspartate aminotransferase, we talked about it, an indicator of liver damage, together with the other aminotransferase, alanine aminotransferase. The increases indicate some kind of pancreatic disease or liver damage. Bilirubin. So if we have a liver lesion, it can reduce hepatocyte cell number and may impair the uptake of indirect bilirubin from plasma and diminish direct bilirubin transport and its clearance. Hence, bilirubin increases are indicative of liver disease or biliary obstruction. Alpha-glutamyltransferase, and this is an enzyme that catalyzes the transfer of the gamma-glutamyl group from glutathione and other gamma, or perhaps let me say Y-glutamyl compounds to amino acids or dipeptides. and its activity is elevated in cholestatic liver disease or some alcoholic or other fatty liver disease, and its increase indicates liver disease. Partial thromboplastin time, this is where we are, is the time it takes for a patient's blood to form a clot, and it's measured in seconds. Its increases indicate liver disease, hereditary coagulopathies, vitamin K deficiencies, and anticoagulation therapy is working. So just to reiterate, it is the time it takes for a patient's blood to form a clot. Prothrombin time, or the prothrombin time, is also an important measure to monitor a patient's coagulation status, and its increases indicate liver disease, just like in the case of partial thromboplastin time. But in this case, prothrombin time goes on to indicate any bleeding abnormalities. Next we have urobilirubin, and bilirubinuria is the presence of bilirubin in urine, and it's usually detected when performing a routine urine dipstick test, and its increases indicate liver disease or biliary obstruction. So bilirubin metabolism occurs in three phases. It can be prehepatic, then there's the intrahepatic phase, and there's the posthepatic phase. Bilirubin is conjugated and becomes water-soluble in the liver, and it's excreted through the biliary and cystic ducts, where it becomes stored in the bladder, and it can pass through the duodenum. In cases where conjugated hyperbilirubinemia occurs, we have a disease process that is affecting the hepatic and posthepatic phases of bilirubin metabolism. Calcitonin, it's a peptide hormone primarily synthesized by the parafollicular cells of the human thyroid gland, and its increases indicate thyroid cancer or some form of anemia or lung cancer. Thyroid stimulating hormone. On a test you might see TSH, and it is the first line screening test for a large number of patients with suspected thyroid conditions. And together with thyroxine and triiodothyronine. So thyroid stimulating hormones increases indicate hypothyroidism. That is to say, the thyroid is being stimulated to produce more of its hormones. Decrease in thyroid stimulating hormone indicates hypothyroidism, and so there's a normal range, and we'll talk about that in subsequent lectures. Thyroxine or free thyroxine T4 or free thyroxine is one of the indicators of the state of the thyroid, and its increases indicate hypothyroidism, and its decreases would indicate hypothyroidism. Triiodothyronine, its increases indicate hypothyroidism, or its decreases indicate hypothyroidism. Now we come to certain urine tests, such as BUN and creatinine, blood urea nitrogen, and serum creatinine. Blood urea nitrogen is a nitrogen-containing compound that is found in the liver as the end product of protein metabolism and the urea cycle. So serum urea levels increase in conditions where renal clearance decreases. So if you have an increase in blood urine nitrogen, it can indicate a number of conditions such as renal disease or renal obstruction. It might also indicate dehydration, GIT bleeding, or congestive heart failure. Creatinine or creatinine clearance is the volume of blood plasma cleared of creatinine per unit time, and it is a rapid and cost-effective method for measuring renal function. So if you have an increase in creatinine, you're probably showing renal damage, renal infection, or some form of renal obstruction. Amylase has played a central role in diagnosing acute pancreatitis. Certain forms of amylase we should be familiar with, the salivary amylase and this pancreatic amylase. And so we can test pancreatic amylase through a blood test or a urine test. And so its increases indicate pancreatic disorders or any biliary or pancreatic obstruction. Note that the biliary system has pancreatic ducts as well. Lipase. Lipase may also be indicative of pancreatitis. In the cases of acute pancreatitis, we would like to look for pain radiating to the back, increased serum amylase, and increased lipase levels. So once again, in conjunction with amylase, lipase indicates pancreatic disorders or biliary or pancreatic obstruction. Serum calcium. High levels of serum calcium may be indicative of parathyroid abnormalities. Prostatic specific antigen. And so this is measuring prostate abnormalities. So I'll just add to this prostatic specific antigen. It has been demonstrated to be far superior to rectal examinations, and in particular transrectal prostatic ultrasonography in detecting early prostate cancer. Hematocrit. Hematocrit is used to detect packed cell volume, and it is used to identify anemia and polycythemia along with other parameters, red blood cell count, hemoglobin concentration, and so forth. And in anemia, where there are fewer red blood cells in the circulating blood relative to total volume of the blood, the hematocrit increases. Smokers and people with chronic obstructive pulmonary disease may also have high hematocrit values due to chronic hypoxia. Hence, the increases in hematocrit are indicative of hemorrhage. White blood cell count. This is indicative of inflammatory disease or an infection, and it's a test used to measure leukocytes. So there are certain normal patient parameters. A patient's body temperature should be around 37 degrees Fahrenheit, measured orally with an oral thermometer placed on the tongue. The pulse of an adult should be about 60 to 100 beats per minute. Adult blood pressure should ideally be between less than 120 systolic and 80 diastolic. Although departmentally the cutoff might end up being 140/70. But ideally you want patients who have around 130/70 blood pressure. Adult respiration, 12 to 20 breaths a minute. So next we come to the cycle of infection. And this is a community health concept, but it is quite important for us to know. Patient preparation for invasive procedures varies among certain clinical facilities. However, we should be informed of how we can maintain a clean environment. So, the first point is a reservoir, and a reservoir is a place on which an organism can grow and reproduce. For example, human skin and animal fur. In the case of a pathogen, the pathogen would exit the reservoir, and this is the escape route for organisms, such as the nose, the throat, the mouth, urinary tract, and wounds. Point 3 is the vehicle of transmission, the means by which organisms are carried about. Examples include the hands and surgical equipment. Point 4 is the point of entry, the part of the body where organisms enter. Examples include a break in skin or the mucosal membranes of the mouth and nose. Point 5, a host that is susceptible. Not every host's body will be infected by every pathogen. Some people's immune systems can fight off viral infections to the point where they never develop clinical symptoms. So you need a susceptible host, persons whose body cannot fight off this pathogen once it infects them. Some invasive procedures are commonly performed in the sonography department, and we need to create a sterile field. And we do this prior to certain procedures such as sterile asepsis, thoracentesis, paracentesis, organ biopsies, mass biopsies, and abscess drainages. So there are certain vital rules for maintaining sterile conditions. We should always know where the sterile items are and which area is sterile. We should know the sterility of an object, and if we are hesitant about an object's sterility, we consider it non-sterile. If you recognize that an item has become non-sterile, sterilize it. A sterile field must never be left unmonitored. If a sterile field is left unattended, we consider it non-sterile. When you're a sterile person, you do not lean across the sterile field, and the sterile field usually ends at the level of a tabletop. Cuffs on a sterile gown are not considered sterile. The edges of a sterile wrapper are not considered sterile. If one sterile person passes another, they must pass each other back to back. Coughing, sneezing, or excessive talking over sterile fields often leads to contamination. So, this is it. Preparation in invasive and sterile procedures. Next we come to instrumentation. Sonographic images are typically recorded and stored in a PAC system, or Picture Archiving and Communication System. PACS allows for both easy storage and comparison between sonographic findings. General abdominal imaging requires the use of a transducer, and our transducers are curvilinear and they balance penetration with resolution. But in general, the higher the frequency employed, the poorer the penetration obtained, but the better the resolution. Conversely, the lower frequencies provide better penetration with a sacrifice in resolution. Transducers that are used for abdominal and small part sonographic imaging include linear arrays, matrix arrays, curved or convex, phased arrays or vector and sector arrays. Higher frequency linear array transducers are used to image superficial structures such as the thyroid, the scrotum, and in MSK imaging, musculoskeletal, as well as to image the appendix or the pylorus of the stomach. A standoff pad or a mound of gel may be used for performing some examinations, such as if we're looking for splinters or for an object below the skin surface. We would use a lower frequency curved array transducer. When applicable, we can use power Doppler, color Doppler, and pulsed Doppler. We can use harmonics imaging, compound imaging, extended field of view, elastography, and three-dimensional sonography. Grayscale or brightness mode provides a two-dimensional image of the human body in real time. And this real-time imaging allows us to view anatomy and motion. The body consists of many body systems, and the levels of anatomical organization. So we can start with the body system level. We have the cardiovascular system, the endocrine system, the lymphatic system, the MSK system, the nervous system, the reproductive system, the excretory system, the digestive system, the urinary system, and the respiratory system. There's some 2D imaging artifacts that we might encounter as we scan, and we have some images of these below. Anisotropy. So anisotropy occurs when the sound beam, the ultrasound beam, strikes a structure in a non-perpendicular manner, resulting in a loss of the true echogenicity of the structure. So in this adjacent image, we can see the left image is obtained perpendicular to the tendon, whereas the right image is oblique, as you can see. This is the left image, this is the right image. The right image is obtained oblique, the left image is obtained perpendicular, and there's a loss of the echogenicity of the tendon. The comet tail artifact, that is a comet tail artifact, and it is a type of reverberation artifact caused by several small, highly reflective interfaces. And we see it with adenomyomatosis of the gallbladder. As you can see, there you are, there's a comet tail artifact. Dirty shadowing, there's your dirty shadowing, this is clean shadowing. This can be caused by air or bowel gas. It's most often seen emanating from bowels, and it may be seen posterior to gas within an abscess. So in this adjacent figure over here, we have dirty shadowing produced by gas, and we have a clean shadow that is produced by gallstone. So we're looking at the area around the upper right quadrant. Edge shadowing. So this is a reflective or refractive effect seen deep to the margins of a round structure, and the structure has a significantly different speed of sound. The sound waves will have a different speed of sound compared to surrounding tissue, and we term this refractive shadowing. It's often seen arising from cystic structures, and it appears as narrow shadow lines originating at the edge. There you are, edge shadowing with some posterior enhancement in this simple cyst. A mirror image. Mirror images are produced by strong specular reflectors, and this results in a copy of the anatomy like that. There is the copy being placed in a deeper region than its correct location. A good specular reflector is a diaphragm, imaged there. And in this image here, you have a mirror image artifact of a hemangioma of the liver. And there's a hemangioma, this is liver tissue, and it has been mirrored in the deeper regions. Posterior enhancement, or what we call through transmission. One of the categorical findings of a simple cyst using the STAR criteria. So this is produced when the sound beam is barely attenuated through a fluid or a fluid-filled structure. So it's seen posterior to fluid-filled structures such as this one here. And one of the fluid-filled structures you will notice is the gallbladder when you're normally scanning, or renal cysts, or in cases of ascites. And in particular, this is a liver cyst, and we can see posterior enhancement. Refraction. So refraction occurs when there's bending of the ultrasound beam when it passes through an interface between two tissues with vastly dissimilar speeds of sound, and the angle of attack is non-perpendicular. So it's seen when imaging through the rectus muscles of the abdominal wall. So here we have refraction caused by the appearance of two gestational sacs when there's only really one. So in image A, one of the gestational sacs has been copied, but in reality there's only one gestational sac. Reverberation artifacts are caused by a large acoustic interface and subsequent production of false echoes. And we see this as an echogenic region in the interior aspect of the gallbladder. And so in this adjacent figure, we have a reverberation in the interior aspect of the urinary bladder. And when we change the angle, it minimizes the reverberation. Ring down artifact. This is an artifact that appears as a solid streak, such as that, or a chain of parallel bands radiating away from a structure. And we see this emanating from gas bubbles within the abdomen, and it can help to identify the presence of air in a structure, or in the case of pneumobilia. So here in this image we have ring down artifact. And so in image A we have air producing this ring down artifact. There we are. Shadowing. Shadowing is caused by attenuation of the sound beam, and it's seen posterior to bone and calculi like gallstones, and also renal stones. And so we have cholelithiasis in the gallbladder over here, and there's a Phrygian cap in this gallbladder, and there's some shadowing posterior to these stones. Side lobes, sound beams that are peripheral to the main sound beam, such as low-level echoes within fluid, can mimic sludge, debris, or pus within a fluid-filled structure. So in this adjacent figure, we have a side lobe artifact, this arrow here, within the rectum, and it's extending into the fluid-dilated ureter. So there's your ureter, there's your side lobe artifact. This is the bladder. Slice thickness. This is caused by compression from 3D to 2D images, and it simulates false echoes that could resemble sludge or debris in the urinary bladder or in the gallbladder. So in this adjacent figure we have slice thickness over here, and it's an artifact, and it has produced a false layering debris, and this is within the urinary bladder. Next we come to Doppler artifacts, and there are a number of Doppler artifacts, but on this image here we have an obstetric image of a fetus here, with Doppler of the umbilical cord. So the legs are there, there's the placenta over there, there's the umbilical cord, there's the head, and the other hands. So these are absent Doppler signal, aliasing, Doppler noise, flow direction abnormalities, and twinkle artifacts. So first and foremost we have an absent Doppler signal, right? And this can be caused by low gain, low frequency, having a high wall filter, or too high of a velocity scale. So we decrease TRF, turn up the spectral gain, decrease the wall filter, and open up the sample gauge. Right. Aliasing. Aliasing occurs when the Doppler sampling rate is not high enough to accurately display the Doppler frequency shift. And increasing the pulse repetition frequency, where we adjust the baseline and switch to a lower transmission frequency, as well as increasing the angle of insonation, decreases Doppler shift. So we have two figures here, we have left and right. So in the left image we have pulsed Doppler aliasing. This is a pulsed waveform of the internal carotid, here we are, showing normal systolic peaks. There you are, systolic peaks. In B, the sampling rate is set too low, and we can see some aliasing. In C, further decreases in the sampling rate produces even more aliasing. The figure to the right, we have color Doppler aliasing. Unfortunately, this image is not colored, but the arrows demonstrate localized aliasing within a stenotic internal carotid artery, and the arrowhead demonstrated true reversal of flow. Doppler noise. If we have inappropriately high Doppler settings, we can generate noise. So to reduce it, we reduce the color gain setting and we adjust the wall filter. And adjacent, we have Doppler noise. A, we have a high filter setting and it produces minimal flow detection. B, we have a low filter setting and it produces excessive noise. C is a medium filter and it eliminates noise and correctly depicts flow. Flow directional abnormalities. These are caused by the sound beam striking a blood vessel at a 90-degree angle, producing an area void of color. And it's very easy to fix. If you have any flow directional abnormalities, you change the angle of insonation. These are examples of some flow abnormalities. Twinkle artifacts. These occur behind strong granular and irregular surfaces, such as crystals, calculi or calcifications. And it's quite useful actually at identifying small kidney or biliary stones. So I have here some functions and structures of various body systems. The cardiovascular system supplies the body with oxygen, nutrients, hormones, and white blood cells to remove waste and toxins by pumping and transferring blood. It has certain organs and structures such as arteries, arterioles, capillaries, heart, the heart, veins and venules. The digestive system provides metabolism, nutrient uptake, energy storage, and the excretion of waste. There's some accessory digestive organs in addition to the stomach. We have the liver, the gallbladder, the pancreas, esophagus, mouth, small and large bowel, stomach. The endocrine system secretes hormones into the blood to control different bodily functions. The hypothalamus in the brain controls the pituitary gland secretion of various hormones, which in turn control the secretion of hormones by endocrine glands. So examples of these are adrenal glands, ovaries, parathyroid glands, pineal glands, pituitary glands, testicles, thyroid gland. They work in conjunction with the exocrine gland, which secretes hormones through ducts, like the pancreas, the salivary glands. We have the lymphatic system, a collection of transportation of excess fluid and absorption of fats, and it also plays a role in immune response. We have the adenoids, bone marrow, lymph nodes, spleen, thymus gland, and tonsils. These are organs and structures involved with the lymphatic system. The MSK system provides structural support for the body, cartilage, connective tissue, joints, ligaments, muscles, tendons. The nervous system controls a large degree of our body, and this includes the brain, spinal cord, nerves. The respiratory system supplies the body with oxygen and removes waste products such as carbon dioxide. Structures associated with it: the bronchus, the larynx, the lungs, the nasal cavity, the pharynx, and the trachea. The reproductive system, production and protection of haploid cells. In males, the epididymis, prostate gland, scrotum, testes, the vas deferens, and females, the fallopian tubes, the ovaries, the uterus, and so forth. The urinary system maintains chemical and water balance and regulates blood pressure, filters wastes. Organs and structures: kidneys, ureters, urethra, and the urinary bladder. Here's an image of the endocrine lymphatic system. I will just increase this. Here we are. So we have the pineal body, the hypothalamus, pituitary gland, parathyroid glands, thyroid gland, trachea, the thymus gland, the heart, the lungs, the islets of Langerhans, the pancreas, the adrenal glands, the kidneys, the testes, or ovaries in females. We have lymph nodes. We have the tonsils, the jugular nodes, the thymus gland, the right lymphatic trunk, mediastinal lymph nodes, axillary nodes, subtrochlear nodes, deep inguinal lymph nodes, bone marrow, popliteal nodes, lymphatic vessels of the lower limb, superficial inguinal nodes, lumbar nodes. There's a thoracic duct, it also has nodes as well. We have gut-associated lymphoid tissue, and we have bronchus-associated lymphoid tissue. There's the spleen and mediastinal lymph nodes. So we come to an overview of the abdominal cavity. The double lining of the abdominal cavity is a peritoneum. The peritoneum consists of a parietal and visceral layer, and the parietal peritoneum forms a closed sac. And this is quite important, except for two openings in the female pelvis, which permit the passage of fallopian tubes from the uterus to the ovaries. That is to say, that the parietal peritoneum has openings in the female pelvis for the fallopian tubes. Furthermore, each organ is covered by a layer of visceral peritoneum. Some abdominal organs are considered intraperitoneal, and others are considered retroperitoneal. The retroperitoneal structures are only covered anteriorly with the peritoneum, and posteriorly they are free. The abdominal parietal peritoneum can be divided into two sections. So the abdominal parietal peritoneum has a greater sac and a lesser sac. The greater sac extends from the diaphragm to the pelvis, while the lesser sac is located posterior to the stomach. There are certain potential spaces which are essential outpoachings in the peritoneum. These exist within organs, and a condition known as ascites can occur, which is an abnormal collection of abdominal fluid in these spaces. We can have masses in the abdomen, which can be neoplasms or tumors. They can be benign or malignant, or potentially malignant. We refer to this as precancerous. And some benign tumors have the potential to progress to cancer. Tumors, whether benign or malignant, may displace adjacent anatomy, and we term this mass effect. So we can move on. Well, I will add that mass effect can cause certain complications or complaints related to pain. So I have detailed intraperitoneal and retroperitoneal organs in this table here. And so intraperitoneal organs include the gallbladder, the liver except the bare area, the ovaries, the spleen except for the splenic hilum, and the stomach. Retroperitoneal organs include abdominal lymph nodes, adrenal glands, the aorta, ascending and descending colon, the duodenum, the ivis inferior vena cava, the kidneys, the pancreas, the prostate gland, the ureters, the urinary bladder, and the uterus. Note that there are far more retroperitoneal organs that are covered only partially by the covered partially by the peritoneum, and we have organs that are completely intraperitoneal. I have also detailed some abdominal spaces. They're not very many, and it is good to understand that these are potential spaces. They're not going to be seen completely on a normal, healthy abdominal scan. So the subphrenic spaces, these are spaces that are inferior to the diaphragm, and we have the right and left subphrenic spaces. Next we have subhepatic spaces. These are divided into the right, anterior or posterior subhepatic spaces, and the left subhepatic space. The right subhepatic space is located between the right lobe of the liver and the right kidney. The posterior right subhepatic space is also referred to as Morrison's pouch, and the left subhepatic space is located between the left lobe of the liver and the stomach. Next we have retropubic spaces. These are spaces between the pubic bone and the urinary bladder. They are also referred to as the space of Retzius. There's the leisure sac, which exists between the stomach and the pancreas. It's a common location for pancreatic pseudocysts. We have the paracolic gutters. These extend alongside the ascending and descending colon on both sides of the abdomen. We have the posterior cul-de-sac. In males, it is between the urinary bladder and the rectum, and we refer to this as the rectovesical pouch. In females, we refer to it as the rectouterine pouch or the posterior cul-de-sac, and it would be between the uterus and the rectum, also referred to as the pouch of Douglas. The anterior cul-de-sac is seen between the urinary bladder and the uterus, also known as the vesicouterine pouch. So we have certain benign abdominal tumors, and we have common locations. Adenomas, which are tumors of glandular origin, are commonly seen in most organs. Adrenal rest cell tumors are tumors containing adrenal tissue. These are seen in the testicle. Angiomyolipomas are tumors of blood vessels, muscle, and fat. These are seen in kidneys. Focal nodular hyperplasia, this is abnormal accumulation of cells within a focal region of an organ. They are commonly seen in the liver. Granulomas, these are tumors consisting of a group of inflammatory cells. These are typically seen in the liver and the spleen. Gastrinomas, these are tumors that secrete gastrin. They are seen in the pancreas. Hamartomas are tumors consisting of an overgrowth of the normal cells of an organ, and these are seen in the kidneys. Hemangiomas are tumors that are highly vascularized, consisting of blood vessels, and these are seen in the liver, the spleen, and the kidney. Hematomas are localized collections of blood, and so it's important to differentiate the two. The hemangioma is a tumor of blood vessels, and the hematoma is a localized collection of blood. These localized collections of blood are seen anywhere an organ or tissue is affected by trauma. Insulinomas are tumors that secrete insulin. They're seen in the pancreas. Lipomas are tumors that consist of fat. These are seen in the liver, the spleen, the kidney. Oncocytomas are tumors consisting of oncocytes. These are seen in the kidney. Pheochromocytomas are tumors that consist of chromaffin cells of the adrenal gland. These are seen in the adrenal gland. Teratomas are tumors that consist of a localized collection, or rather, let me say, teratomas are tumors that consist of all germ layers. These germ layers are the endoderm, the ectoderm, and the mesoderm. So I'll just repeat: the ectoderm, the mesoderm, and the endoderm, and they are commonly seen in testicles and ovaries. Urinomas are localized collections of urine, and these are adjacent to kidney transplants. So these are all benign abdominal tumors, and note that a large number of benign abdominal tumors have the suffix oma: oncocytoma, pheochromocytoma, teratoma, urinoma, lipoma, insulinoma, hematoma, and so on and so forth. We also have malignant abdominal tumors. And these carry with them I wouldn't call it a prefix, but I would say they carry the suffix carcinoma or sarcoma. And these are some of the locations of these tumors. We have adenocarcinomas, which are cancers of glandular origin, and they're seen in the pancreas and the GIT. Angiosarcomas, these are cancers of the lining of blood vessels, lymphatic and vascular, seen in the spleen. Chorlocarcinoma, these are cancers that consist of trophoblastic cells, seen in testicles. Cholangiocarcinoma is the cancers of the bile duct, is seen in the biliary tree. Cystadenocarcinoma are cancers that are fundamentally adenocarcinomas with cystic components. And we said adenocarcinomas are cancers of glandular origin, seen in the pancreas and the GIT. When they carry with them a cystic component, we refer to them as cystadenocarcinomas, commonly seen in the pancreas. Embryonal cell carcinoma is cancers that are of germ cell origin, seen in the testicles. Follicular carcinoma, these are cancers of aggressive abdominal epithelial cells, these are seen in the thyroid. Hepatocellular carcinoma, or commonly referred to as a hepatoma, are cancers that originate in hepatocytes, these are seen in the liver. Hypernephroma or renal cell carcinoma are cancers that originate in the tubules of the kidney, seen in the kidneys. Leukemia, this is a cancer of blood vessels, seen in the spleen, liver, and testicle. Lymphomas is a cancers of the lymphatic system, seen in the spleen, kidney, and testicle. Medullary carcinoma, these are cancers originating from the parafollicular cells of the thyroid, seen in the thyroid. Papillary carcinoma is also seen in the thyroid, are cancers that have many irregular finger-like projections. So these two, medullary carcinoma and papillary carcinoma, are seen in the thyroid, but there are certain differences. Medullary carcinomas originate from parafollicular cells of the thyroid, whereas a papillary carcinoma has finger-like projections that are irregular. Seminomas are cancers that originate in seminiferous tubules of the testicle. Transition cell carcinomas are cells that originate in the transitional epithelium of an organ or structure, such as bladder, ureters, and kidneys. Yolk sac tumors are cancers of germ cell origin, and these can be seen in testicles. So the tumor markers that we look at, such as alpha-fetoprotein, and the possible cancers are liver cancers, ovarian and testicular cancers. Cancer antigen 15-3 are actually alpha-fetoprotein and human chorionic gonadotropin aid in classifying and staging germ cell tumors for ovarian and testicular cancers. Cancer antigen 15-3 has been found in the serum of more than 70% of patients with breast cancer. So whenever you see cancer antigen 15-3, it is indicative of breast cancer. It is also present in almost 70% of metastatic breast cancer events, to the point where cancer antigen 15-3 is a promising biomarker for early detection of breast cancer. That's cancer antigen. This is carbohydrate antigen 19-9. So just to reiterate, this is cancer antigen, and this is cancer antigen, but this is carbohydrate antigen, and it was first described in 1979 and it is a cell surface glycoprotein complex produced of ductal cells in the pancreas, the biliary system, epithelial cells of the stomach, colon, uterus, and salivary glands. And carbohydrate antigen 99 is overexpressed in many benign and malignant gastrointestinal and extra-gastrointestinal diseases, but its main implications are in pancreatic ductal adenocarcinomas and intraductal papillary mucinous neoplasms. But it can be elevated in biliary, hepatocellular, GIT, urological, and a number of other cancers. So carbohydrate antigen 99 is indicative of pancreatic, biliary tract, stomach, and colon cancers. Cancer antigen 125. It's an antigenic tumor marker expressed by epithelial ovarian neoplasms and cells lining various organs such as the endometrium, fallopian tubes, in some cases pleura, the peritoneum and pericardium, but largely ovarian cancers are indicated in the cases of cancer antigen 125 being detected. Calcitonin. This is one of the hormones produced by the thyroid, and in a large portion of patients with medullary thyroid cancer, the calcitonin level is increased. Therefore, calcitonin is a sensitive tumor marker for medullary thyroid cancer. Beta HCG, or human chorionic gonadotropin, is a hormone found in blood and urine during pregnancy, and it may also be found in higher than normal amounts in patients with certain types of cancer, including testicular and ovarian cancers, as well as liver cancers. So beta HCG is indicative of testicular and germ cell tumors. Lactate dehydrogenase regulates the processing of glucose to lactic acid, and its levels are commonly increased in cancer patients, and it is correlated with poor clinical outcome and resistance to therapy. So it's a hallmark of cancer cells, and it indicates increased energy requirements associated with a higher rate of cellular proliferative activity. And so it indicates cancers of testicular, ovarian, and other germ cell tumors. Just to make it easy to memorize these tumor markers, we have alpha-fetoprotein, cancer antigen 15-3, carbohydrate antigen 19-9, cancer antigen 125, calcitonin, beta human chorionic gonadotropin, and lactate dehydrogenase. We have certain abdominal disorders, such as autosomal dominant polycystic kidney disease, and it is an inherited condition that causes cysts in multiple organs, usually seen later in life in patients, in the kidneys, the liver, spleen, and the pancreas. There is a recessive variant, or autosomal recessive polycystic kidney disease, also inherited, also causes cysts in the kidneys or the liver, but it's usually discovered in utero or in newborns. So that is the main difference. The difference is clinical, in so much that autosomal recessive is discovered in utero or in newborns, whereas autosomal dominant is discovered usually later in life. HIV is a virus that attacks the immune system, and we see it as a Kaposi sarcoma in the liver, the spleen, the lymph nodes, and skin tumors. Beckwith-Wiedemann syndrome is a growth disorder that causes enlargement of many organs and structures, as well as increased risk of kidney and liver cancers in children. And we see this as visceromegaly and the macroglossia, Budd-Chiari syndrome. This is a narrowing or occlusion of hepatic veins as well as the IVC, but not necessarily. And we see it in the liver, and the IVC. Cohn syndrome results from high levels of aldosterone, and it can be caused by an adrenal adenoma seen in adrenal glands. Crohn's disease, an autoimmune disease that causes chronic inflammation of the GIT, seen in the GIT. Cushing syndrome, resulting from high levels of cortisol, can be caused by adrenal adenomas, seen in adrenal glands. Diabetes, caused by hyposecretion or hypoactivity of insulin. We have type 1, which is early onset, juvenile, and type 2, which is adult onset. Multiple organs can be affected, including the eyes, the kidneys, extremities, nerves, and vasculature. Fitzhugh-Curtis syndrome, a rare complication of pelvic inflammatory disease, causing inflammation of the tissue around the liver, affecting the liver. Graves' disease, associated with hypothyroidism. Hashimoto's disease, associated with hypothyroidism, or both affect the thyroid. We have other conditions. Klinefelter syndrome, genetic condition in which a male, let me say, has an extra X chromosome. So it affects the testicles, and there's development of male breast tissue. Marfan syndrome is a disorder of connective tissue, affects the heart, vasculature, and the skeleton. Mirizi syndrome shows up as jaundice, pain, and fever, associated with stone lodged in the cystic duct, affects the biliary tract. Nephrotic syndrome, damaged filtration of kidneys, causes excessive protein in the urine, or we call it proteinuria, affects the kidneys, swelling of feet and ankles. Sarcoidosis, it's an inflammatory disease that results in scar tissue development in multiple organs. Sarcoidosis affects the liver, the spleen, kidneys, testicle, lymphatics, and lungs. Tuberculosis is an infectious disease spread through the air. Well, I should say spread through infectious droplets in the air, and it affects the lungs. We see it as caseations. It can also affect lymphatics as well as the abdomen. That's not mentioned here, but there's abdominal TB, and it also affects the testicles. Tuberous sclerosis, it's a rare genetic disorder that leads to development of tumors within various organs. Tuberous sclerosis affects the brain, heart, and kidneys as angiomyolipoma. Von Hippel-Lindau disease is a rare genetic disorder characterized by cysts and tumors in various organs. It affects the pancreas, kidneys, and adrenal glands. Zollinger-Ellison syndrome usually is a gastrinoma in the pancreas or intestine, and it causes an increase in the production of gastrin. And if it is in the stomach, it will produce excessive stomach acid. So thank you for attending this first lecture of this series. We shall meet next week for another lecture. All right.